Dr. Vinod needs no introduction to my friends from Punjab. He was one of the most popular refractive surgeons of my region. People will hire taxis and cars to reach Dehradun to get their refractive surgery done. This is what I know of Dr. Vinod, and what you know about him is written. And he is a perfect organizer, a scientific thought, brought many new additions to the conferences. 2 minutes to win. See, 2 minutes video and you win a prize. That means you took hours to create those 2 minutes. This is the creativity of Dr. Vinod Arora. Rest, I don't want to explain because you already know. Dr. Arora, please, the dais is with you.
Thank you so much for your kind introduction. And coming to the refractive surgery, I think the things keep on coming back and back. So it started with RK. If we're talking about the corneal refractive surgery, it started with RK, then PRK, then LASIK, then LASIK, intralaser, epilasic, SMILE, Contura Vision, advanced surface ablation, Wavelight Plus, all the things are coming. And the beauty are that they are staying there. So we'll just have a fair essay of these things. PRK initially was more accurate compared to RK. It was able to correct myopia, hypermetropia, astigmatism. The results were pretty stable. But initially there was a broad beam lasers. We have a lot of pain in these patients. There was a delayed healing. There was a scarring. Then came the LASIK. There was a wow factor. There was a rapid recovery. There was decreased risk of scarring. There was practically no pain in these patients. But some of the flap-related complications, of course, not common, but still they are. Like flap striae, buttonholing, partial flap, debris, epithelial growth, DLK, late trauma, and the most dreaded one is the ectasia. It may occur in very minuscule of cases. Then came the femto. It was a thinner flap, fewer incomplete flaps or buttonholing, flap-related complications were practically gone, but some problem with the femto still persisted. Like Dr. Dhami has told you, photophobia, rainbow effect, higher DLK, late trauma, and can displose the flap, and ectasia may be there. Then came the SMILE. It's a very good procedure, but at present, what we were talking, some limitations are there. You can't correct hyperopia, customized treatment, not possible at present. Difficult in low power correction, you have to correct a lot of take a table along that one. Bitoric, big astigmatism are difficult to treat with this one. Treatment is centered on the pupil. No cyclotorsion compensation. You can do it manually, but as such there is no cyclotorsion compensation. If you do a little decentration in the LASIK, it will not affect the refractive outcome. But for SMILE, it can cause higher coma. High coma, I think, is very, very common in SMILE patients and may persist up to 6 months in these patients. Then coming to my topic, that's advanced surface ablation. What are the indications over LASIK and SMILE? You can do it in irregular astigmatism, even in FFKC, if the cornea is thin, if there is a night vision concern like glare from large pupillar flap, there is an anterior stomal opacity you can correct along with your treatment. Then if the chances of contracted sports or hazardous duties, if there is a history of prior RK or AK, we are getting a good number of patients like that. And if you want to do wavefront treatment or customized treatment, and in the patient, if there is a RD surgery, filtering blab, deep set eyes with prominent orbital loop, we can't fix a ring on those patients. So it's very, very safe in those patients. And of course, you can combine it with C3R. The contraindications are just like any refractive surgery: herpes zoster, dry eye, glaucoma, irregular astigmatism, especially ectasia or KC, PMD, keratoglobus, uveitis, if there is a lenticular changes, and if there is a progressive retinal pathology like myopic degeneration, diabetic retinopathy, RP or RD is there. Then systemically, if there is a diabetes, don't do in pregnancy, lactation, rheumatoid arthritis or SLE, these are for general for all refractive surgery. Abnormal wound healing, keloids or Marfan syndrome, systemic infection is there, HIV or TB, If a patient is on drugs, you have to see that. If it is on antihypertensive, antipsychotic or antiparkinson's medicines, or these all causes dry eye and fluctuation of vision. Then as far as ESC is concerned, probably it is one of the safest procedure compared to all the corneal refractive surgery, because we are creating a lamellar cleavage. That's not in this procedure. And all the studies have demonstrated that the chances of getting ectasia is probably lowest in advanced surface ablation. The advantage of, again, not only ectasia, but you can even correct high number also. And the range, earlier we were doing it for LASIK rejects, and the range was around 3 to 4 diopters. But now the range is as good as of any LASIK or SMILE patient. So you can combine it with PRK. The goal of treatment using the topo-guided software is to normalize the corneal surface and improve best corrected visual acuity. I'll not go into detail, but say topo-guided treatment. So we just regularize the cornea. We don't take out the all refractive component, just try to regularize and use the minimum tissue. Coming to the techniques we were using earlier, this was very, very simple. Putting a local anesthetic drop, there is a removal of epithelium by maybe by manual, maybe by OMIs, there may be laser can be used, or it can be alcohol assisted. This is, we remove the epithelium, laser is applied, and we use mitomycin, bandage contact lens. So it's very, very simple. There's no learning curve. Anybody can do on day one. Nothing is required. Only thing, he has to be good at refraction, what we were discussing. Dr. Monica has told you. Every refractive surgeon has to be very, very good at refraction. And he himself or herself should do it. Don't depend on your optometrist. And confirm and reconfirm in every visit. Antibiotic lubricating drops. So what were the complications which we were getting with the earlier systems? We were doing PRK, but there are some problems like stomal scoring, irregular astigmatism, persistent corneal epithelial defects, recurrent epithelial erosions were there, and epitheliopathy. These are some of the complications which were we getting earlier. And we did so many things to improve our results. Like preoperative, careful preoperative checkup is a must. Look for the lid hygiene. Blepharitis, you do a good hygiene, scrub and antibiotics, manage it. If there is a dry eye, manage it first, then go for your treatment. Dry eye is very common in a middle-aged patient, and of course it's getting very common in youngers also. Then again in the operative procedure, we are using word modulator. There is a mitomycin, which has to change the game, and it prevents the haze. Chilled BSS, proper fitting contact lens is again very important. Contact lens soaked on Acuvil or Acusat, what Dr. Rohit Shetty has propagated, is good for reduction of pain. Of course, I'm not using it now. Newer contact lenses are coming instead of bandage contact lens, which will dissolve itself. I think that will be a great thing. Then NSAID should not be used. Don't limit it, if you are using limited 4 to 5 days. Then mitomycin. It's a potent antimicrobial which inhibits DNA, cellular RNA, and protein synthesis. It blocks keratocyte activation and proliferation, causes myofibroblast differentiation and subepithelial collagen formation. It results in preventing anterior epithelial stroma scoring. The drug is available in a vial. It's how you can dilute it and use it. Avoid any wrong mixing. You have to be very, very particular about that. And depending on the time, you can use for 12 seconds to 120 seconds, but I'm not using it for more than 60 seconds. And post-operatively, avoid overuse of topical anesthetic. In fact, I don't use at all. Oral prednisolone given for a day or two helps a little bit. Oral pain agents are now much better. And we have got gabapentin, pregabalin. You can use Ultrasat, or these are very, very good drugs and reduces the pain a lot. Then again, we have to improve the epithelial regeneration. We have to remember the hair, the healing is by epithelium. So the epithelial regeneration should be good. If you find any defect, use doxycycline 100 mg BD for 7 to 10 days. avoid UV exposure. I always give a good quality UV blocker goggles to them for my clinic only. I don't ask them to buy from the market because we are not very sure. Then nutrition supplements help in early recovery. This is the third thing which has changed a lot. That is the epithelial remover. That has come in a big way, which has changed the whole game. It's from Schwind. So what Schwind did, they just collected the data. They just collected the data and make a, it's like AI system. They made epithelial mapping and channelize this system, his pattern like whatever is common in most of the patients. So if you talk of central, it may be around 50, 40, 45 microns. There may be 10 to 15 micron extra on the peripheral side. So they try to mimic whatever the data is available with that. They created the pattern, which gave a very, very smooth surface. Then came the stream light from Alcon. It's again, I'm using this one. It's again very, very good machine. What they did is, it's a, what is the difference if you talk of the PTK and PR, present advanced surface ablation? In PTK, we were introducing around 0.75 or more of myopia. But at present, this PTK is neutral in advanced surface ablation. The surface is wavefront optimized profile. That means it's taking little more tissue on the sides as compared to center. So that causes very, very smooth surface. It mimics the human epithelium. And again, it's a one-step procedure. That means you are removing epithelium plus you're doing ablation in a single click. So this thing has changed a lot. Our range has gone up to 10 diopter. In LVP, they are doing up to 13 or 14 diopter. Of course, after 8 diopter, my first choice is ICL. But some of the patients who are not willing ICL or not fit for ICL, I go up to 10 diopter. You can correct hyperopia, hyperopic astigmatism, mixed astigmatism also with this one. Then it's a one-step procedure. There is a no time lag. And first epithelium is removed, followed by refractive correction done. Optical zone selection again is very important because you use the minimum optical zone required corresponding to refractive zone. That means the epithelium you are removing is the minimal compared to any other procedure using alcohol, manual or whatever you are using. Here the epithelial removal is minimal, rest of the epithelium is very healthy. That's why the recovery is very fast and quick. Less myopic shift compared to standard PTK mold. There is a uniform removal. There is no islands of epithelium as such. Epi-ablation zone automatically determined by the laser based on the PRK ablation profile. There is active eye tracking throughout the entire process. So just to summarize the advantage of transepithelial PRK at present, there is an accelerated healing and visual recovery by limiting minimum epithelium removal. There is a less pain in these patients, reduced risk of haze by accelerating healing, by smooth surface and better contour, by removing damaged cells, and by reducing thermal effect. The drawbacks or shortcomings, you can say, the flip side is that it accentuates the importance of epithelial mapping for the proper surgical planning. It causes more heat. It's still not available with premium profile like Custom Q or Contura. But even if you want to do it, you can do in a two-step procedure. That means you remove epithelium with this pattern, and then you can do Custom Q or Contura, whatever you want to do, or wavefront optimized treatment. And it has a price tag. So advanced surface ablation is a gentle, no touch, no cut, no incision. It's a safe, more biomechanical preservation of the corneal stability. It's a stress-free, faster treatment in a single step. There's no effect on the posterior segment. You're not putting any pressure. There are excellent clinical outcomes. Reduces dry eye by leaving nerves that can produce tear intact, can be combined with CXL, economical for you, easy to use, time saving, low investment, no need of femtosecond laser or even microacutome for that matter. Just to conclude, these three things which has made the resurgence of surface ablation, there is a better XMR profile. We get a finer flying spot, mitomycin C, and better epithelial removal profile. That's a wavefront optimized one. Surface ablation is one of the most effective tools in the surgical armamentarium of refractive surgeon. It is still underutilized, but a very promising and exciting with superior results. Thank you. Thank you very much. Now we are
Dr. Vinod,
Yep.
we have heard you many times, and this is your pet favorite topic. But everything you add something new, that's wonderful. I have one question. You talked about Streamlight. I know only Streamlight because I am a Alcon user. Do you measure epithelium thickness in every case?
Ideally, it should be done because basically the epithelium thickness doesn't matter much. Only thing if there is an epithelium abnormality somewhere, then your result will be affected. Suppose your thickness is 50 microns and you put a 55 microns, it's not going to affect your refractive outcome. Suppose you put a 55, it's a 60 micron, it's not going to affect your refractive outcome. So it doesn't require that way, but if there is an epithelium abnormality, because here the healing is by epithelium. Unlike LASIK, SMILE or other procedure, the importance of epithelium healing is probably the most clear. So if you can have, it's very, very good.
No, little exaggerating the question. If the epithelial map shows islands like 58, 60 micron thickness, but in Streamlight we can go only up to 50.
No, you can up to 55. You can do 55. I routinely do 55. You can do up to 60 also.
Really? I'll check.
Yeah, we can. I'm routinely doing 55 for most of the cases.
Okay.
If the cornea is thin, then we reduce it again because the epithelium may be thin in those cases.
If the epithelium is thinner, you'll.
Cornea is thin, that epithelium
No,
layer
no,
will be
if
thin
the
also.
epithelial thickness is thinner,
Yes.
you will do a thinner ablation.
Pardon?
If the epithelial thickness is 45,
Basically, if you are correcting very low, say 0.5 or something, then it matters. But if you're correcting around 3 or 4 diopter, it doesn't matter. Your refractive outcome will not change even if you not put it properly. No, of course, having measured it and doing it is a proper way to do it.
My question is a little different, that you measure the epithelial thickness and accordingly feed to the laser to correct.
Yes.
Then do trans-PRK.
Yes.
Trans-epithelial.
Yes, that's the way.
If it is beyond the range of what you can fix
If there is any problem with the epithelium, I'm going to say
the laser machine
45 is normal, 55 is normal, 60, 65 is normal. If you're getting 85, that means something is wrong with the epithelium. You have to look at the patient again. So normal range is around 40 to 60 micron. So that's a normal range for epithelial growth.
That will you go with 50 microns in the machine?
No, you can do it to 40, 45. It has you can change the epithelium.
Streamlight gives, I'll check when I go.
In Alcon, it is there. You can just modify whatever you want to do.
You cannot modify beyond 50.
No.
Sir, initially I think it was 55 when I was using this machine and I had discussion with sir also. I had a patient 65 microns of thickness and that is what I discussed, and at that point of time it was not possible I think to change the exactly what you're saying. I think now I have...
Dr. Dhabi, what you're confusing with the PTK?
No.
In PTK, it restricts you.
No, I'm talking only about Streamlight.
No, Streamlight, there is a quite good option. You can choose any thickness you
I'll
want.
have to check because then I have to get it done
Yes,
in my
yes.
machine. Thank you.
For PTK, there is a limitation. You can do the limited ablation. If you go beyond that, it will stop. Suppose you are choosing a zone of around 8 micron. It will limit you around 40, 45 somewhere. If you are choosing a 7 micron, it will allow you up to 50 microns. That's inbuilt in Alcon as such.
I have experience with the Schwinn now, the latest one, and you can, this default is 50. In the center, periphery is slightly different. So
Yes.
it has about 5 to 10 micron difference. So 50
Yeah.
if it's center, 58, 55 or 60. The second part is you can modify with the epithelium ablation. Most of but the machine which you measure it, there would be a variation in terms of the epithelial thickness, because epithelial thickness, what we have found for the same patient, the variation is usually 5 to 10. Same machine,
Yes.
10 minutes apart, you will have variation
Yeah,
about.
see, I think it's not very, very reliable what you're seeing presently on the OCT. It depends on the optical surface at that time, maybe tear their time. So there may be some variables, but it hardly affects your refractive outcome. If the epithelium is healthy, doesn't matter much.
That's the only. That's why I said whenever I hear Dr. Vinod, I carry on something new. That's
Please.
great, sir. And now, one thing more, that when do you
I'll
shift
come
to
back.
alcohol?
So sir has beautifully summed up all the technologies available, and only one point to be added in trans PRK. The best part of this machine is that the epithelial removal which it does is the margins are quite smooth because it is done with a laser. So the manual separation anyways we do with hockey stick or any other technology. The best removal of epithelium is with trans PRK, either Elcon or Schwint. But yes, the point sir highlighted, if possible, we should measure epithelial thickness in our patients. And if it is possible, as sir said, we should feed so that, we become more precise.
Yeah, my question is a bit similar only because I have EX500, but I have still not done a single streamlight on it because I do normal PRK. I use alcohol, remove the epithelium, and then do PRK. Because worrying about this situation, because even if in a normal, in a normal cornea, the epithelial thickness will not be uniform in all the nasal, and it will be more in the nasal and inferior than. So I was wondering whether we should have proper some maybe anterior OCT to find out the exact mapping and then go for it.
See,
or we,
just cut me short you. If you do with the OCT, you can adjust only the central thickness profile in your machine.
Okay.
You can't adjust 65 AR, 45 AR,
Achha,
35.
you can't do that.
That's
Okay.
not possible in the machine.
Okay.
Secondly, what in Schwinn they did a study in a large human population
Okay.
and did the epithelial mapping. And based on that pattern, they created the smart surface pattern.
Okay.
In Elcon, they did a similar thing, but it make a wave, this called wavefront optimized. That means we know the center thickness is around 50. In the periphery, I might say around 7 millimeter, it will be around 65.
Yeah.
So just like they've created the profile, what is very common in the most of the humans. So you can't change it based on the OCT except the central thickness.
Okay.
Yeah. So, but I'll just tell you, if you use this thing, this is a very good, much superior what you're doing alcohol.
Yeah.
There's no collateral damage to the surrounding tissue. That's number one.
Yeah.
Whatever the precaution you took, some alcohol may sweep there.
It always.
Even the minuscule of very, very microns or something, it will spill there. So that will damage your cells.
Yeah, exactly.
So it keeps the collateral cells very, very healthy. That's why you will find the much better recovery.
So previously I was doing first PTK and then I was doing laser. For these patients, I was doing using the PTK mode and then I was doing the excimer laser. So is that also okay if I do with that?
Only thing, it introduces a little bit of myopia. You have to just adjust in your nomograms.
Okay.
Second, the removal is not uniform that I was telling you. It will remove the epithelium 50 micron all over.
Oh, all over, right.
Yes.
So
It will-
streamlight is much better than.
Streamline is much better that way. Even if you are using alcohol, I'll say don't do with the laser.
Yeah.
They will get a very smooth surface and your surrounding structure will be saved. Even if you're not doing this streamlight.
Okay.
Even with alcohol, you can do that also.
Pardon? Not streamlight means?
Don't use alcohol.
Okay.
And if you're not using steam light, you just do the laser scraping of the epithelium. Remove by laser. Like a PTK mode even does.
Achha, even that will be better than the.
That's give you better results. Your recovery will be very smooth.
Yeah, I know. Thank you, sir. Thank you.